You know what needs to change. You know what's wrong. We gotta treat people the same. We gotta get along. Do you know the history of the country where you stand? Do you know how they treated the first people of the land? Do a little research. I know that it might hurt. Open up your mind, son. Then come back, we can rewrite. Do a little research. I know that it might hurt. Open up your mind, son. Then come back, we can rewrite. Come back, we can rewrite.
Hello again. I just wanted to recap on that welcome to country and acknowledge all the other Indigenous families and people here today. Shiree and Athira, we're here to talk about our project that we're doing through Menzies, and it's covering youth type 2 diabetes, a prevention program consultation project that we're working on. I gave you a little bit about myself, so I'll pass it on to Athira.
Thanks, Shiree, and thanks for the welcome. Hello, everyone. My name is Athira, and my family is from the southern regions of India. I'm a research officer who's working with Menzies School of Health Research based in Darwin, and I'm with the Menzies Diabetes team. I'd also like to acknowledge the Arande people, the traditional owners of the land, and I'd like to pay my respect to elders past, present, and emerging, and all the Aboriginal Torres Strait Islander people who are here today. So I'll be talking a little bit background about the project, how we came about this, and Shiree will be talking about how we did and key findings. Our project falls under the umbrella of the Diabetes Across Life Course, the Northern Australia Partnership Program, led by Professor Louise Maple Brown up in Darwin. So our project particularly was focused on young people. It was in response to an identified need of addressing the emerging rates of youth-onset diabetes and obesity. So the project was developed in response to requests from many communities and reference groups, including Indigenous Reference Group, Clinicians Reference Group, and Youth Diabetes Working Group. Our project had two aims. Aim 1 was to understand the needs and experience of young Aboriginal and Torres Strait Islander people in Central Australia. And also Aim 2 was to adapt a behavioral lifestyle intervention program to improve the cardiometabolic risk of children in Central Australia. I'll talk a bit about Aim 1, and this was led by Dr. Renee Kirkham. Young Aboriginal and Torres Strait Islander youth were interviewed in 2 Central Australian sites, and these were the key findings from the interviews. As you can see, diabetes affected young people's identity. It caused shame, which contributed to feelings of isolation and disengagement from services. And also, diabetes was not always a priority for young people. There were other comorbidities, other caring responsibilities. However, our finding indicates that creating a youth-friendly diabetes clinic was having a positive impact in relation to the engagement with services. Today's focus of presentation is on our Aim 2, which was to develop a culturally appropriate and family-focused diabetes prevention program targeting Aboriginal children 6 to 11 years old and their families. The proposed program would be an adaptation of an internationally successful youth diabetes prevention program. This was trialed out in the First Nation communities in North America. And the term was Tribal Turning Point, or TTP. So TTP stood out because of its strong partnership with communities. It was led by members of the community, and it was widely accepted by the families who participated in the program. Our project had 2 components, so this is again a formative work. So it was all about consulting with the community about this program on how suitable it is in the Central Australian context. So we had community consultation and we had a revision of the program manual. And we were backed up by multiple advisory groups. We formed a technical reference group with 10 expert members representing community, cultural advisors, researchers, clinicians, dietitians, etc. And they have assigned a dietitian working group for nutrition and diabetes content-related expertise. And as I mentioned before, our wider partnership program is under the guidance of the Indigenous Reference Group. We had that, and in addition, we had a cultural reference group to ensure local culture and language needs. We expect, this is a formative work, we expect to adapt this program in the Central Australian context, and attract future funding for actually trial out a pilot program for this prevention program. This is our team, and listed are our key partners and collaborators. With that note, I'll hand over to you, Shiree, for the fun part.
When we done the community consultations, we held about 14 workshops with service providers, cultural advisors, parents and families. When we talked to all the families and things, they gave us plenty of ideas and lots of interesting things about what they were interested in with this program. There was healthy lifestyles that they was particularly interested in, but there were some concerns as well about keeping our mob captivated and keep coming back. They loved it and it was really deadly, but they were being brutally honest too, saying, how are we going to keep these mob coming back? And to finish that 10-week course. So it was really valuable sitting down talking to these families with what they had to give us, you know, what their thoughts were on the whole project. We consulted with families in various places. It was where they were comfortable. We went to their homes, we went and sat down at the community centre in our town camps with families, and even young lot of families came into the office, so that didn't faze them. So it was about making them comfortable and letting us know, you know, them letting us know what they would like. I'll just go over a couple of quotes that we got out of all the interviews that we'd had done. There was one from a cultural advisor saying the program needs to come from a more holistic approach rather than a deficit model, and that was just from cultural advisor. And then a parent, it's a good program for people that want to make change, already making change, just some slight changes. Another one I'd like I said before, the program is very important for our children. We want them to be happy, to live happy, healthy lives. I think people would engage more if they related to the person. So definitely a local person to facilitate this program. Be flexible. Must be flexible if you're working with a family. I think more hands-on stuff rather than sitting down and talking. And that's from a community member. So those are just a few quotes that came out of our interviews over time. And then the program revision, it started with preliminary findings with the dietitians working group, and then onto the cultural advisor review, detailed revision by the dietitians working group, and then we have a working cultural reference group which is still underway. That picture there is of one of my homelands, and we've got a couple of family members just rocked up, so that's our homelands up there. I just wanted to share that with you. I think that's it. And then I'll let Athira keep going.
Thanks, Shiree. So it was clear from our consultations that community want to own the program and they want to lead that program. So our ideal next step would be for any local Aboriginal community-controlled health organizations like Congress to lead future funding application, and we can provide research support from us. The next step would be acquire funding for a pilot trial for the adapted program. At the moment, we plan to publish the adapted program manual, so it's out there and anybody interested can take up the program. With that note, thank you so much, everyone, for listening, and we thank families, service providers, funders, and partners. And thank you.
Thank you.